Good afternoon and welcome to our series of webinars focused on bringing you information about COVID-19 related topics. The information in these weekly webinars is geared toward long-term care and skilled nursing facilities, but we encourage everyone who's interested to attend. My name is Kathy Caudill. I'm a communications specialist with Quality Insights. Everyone has entered the meeting on mute, but we will have a discussion following the presentation. So if you have questions or comments, please submit them using either the chat or the Q&A tool in your Zoom menu. You can also raise your hand at that time to request to be unmuted to ask your question out loud. Today, we'll be discussing recent guidance changes now that the PHE, or Public Health Emergency, has ended. This is part one of a two-part series by Quality Insights Medical Director, Dr. Jean Storm. Today's webinar will focus on guidance changes affecting long-term care facilities, home health, and hospice. Part two, which will be held tomorrow at 1 o'clock, will focus on guidance changes affecting acute and continuing care facilities. And while part one is recommended for this audience, anyone interested in part two may attend that webinar as well. If you would like to attend tomorrow's webinar, I will share a link in the chat shortly with details about how to register. Dr. Storm, please click to the next slide. Thank you. So today's webinar is eligible for nursing continuing education credits. You can see details about those credits here. If you're interested in obtaining credit, you'll need to stay for the entire 45-minute webinar and complete an evaluation and knowledge check. We'll share the link to that evaluation at the end of today's discussion. And now I'd like to introduce, and now I'd like to introduce our presenter today, Dr. Jean Storm. Dr. Storm is a medical director here at Quality Insights. She has a background in nursing home care, internal medicine, and healthcare leadership. Most recently, she served as Associate Medical Director for Optum United Healthcare. She has also served as Regional Medical Director for 38 long-term care facilities in West Virginia. She earned her DO from Lake Erie College of Osteopathic Medicine and completed her postgraduate training at Mill Creek Community Hospital in Erie, Pennsylvania. Dr. Storm, thanks for joining us today.
Thanks so much, Kathy. And I'm going to start with the objectives. I just wanted to give a little background. I was a clinician practicing in the nursing home environment, and in the hospital during the pandemic. And I can tell you, when I heard that the public health emergency was ending, I was delighted. But it's really interesting because I think a lot of us have gotten used to what has gone on during the pandemic, and you know, I think that we might be thinking that is normal. That's normal times, but now we have to transition back to pre-pandemic regulations, and we might just need to be reminded of what the regulations were prior to the waivers being enacted, because we've had the waivers enacted for a fairly significant amount of time. And I will say pandemic time is a little different than regular time. So that's what we're going to talk about today. I apologize in advance that if it's a little dry, but if you have any questions, feel free to save those till the end and I can take those. I did include in the slides, on most of the slides, a link to the regulation, because since some of these regulations, I've abbreviated them a bit. One of my coworkers said this is the Cliff Notes, because the whole document is fairly long. So I wanted to kind of get the gist of each waiver that is being lifted at this point. And then if you want more information, you certainly can use the link or ask a question at the end. So the objectives are to identify the changes that all providers across all healthcare environments must make with the ending of the health emergency. There's extensive waivers that were put into place for long-term care. So now they've changed a little bit now that the public health emergency has ended. Some are actually staying in place, and some have been lifted. So we'll be talking about those around COVID-19 infection reporting and vaccination and vaccination education. We're going to be talking about the compliance timelines for the ending of the public health emergency. And that's the same slide. Okay, so 3 years and 100 days. That's a long period of time. I saw this and I was like, my goodness, that was a long period of time. Like I said, pandemic time is a little different. So now we are back in peacetime mode. So let's talk about, what that actually means. So just a little background of the public health emergency. On January 31st, 2020, the Secretary of the Department of Health and Human Services, Alex Azar, declared that the novel coronavirus, the COVID-19 infection outbreak, a public health emergency. And so he is allowed to do this under Section 319 of the Public Health Services Act if he determines that a disease or disorder presents a public health emergency, or that a public health emergency, including significant outbreaks of infectious disease or bioterrorist attacks, otherwise exists. So that's how he can do what he did. So waivers and regulations, some changes during the public health emergency involve more regulations, like the vaccine mandate, where all healthcare workers were required to get the COVID vaccine. That was allowed to be done through the public health emergency. But most of the changes made as a result of the public health emergency resulted in a relaxation of some of the regulations, so we could all focus on doing what we needed to do during the pandemic to take care of patients. And again, like I said, these waivers allowed us to really focus on patients and do what we needed to do. It's important to note that CMS has issued waivers that have already terminated prior to May 11th, 2023, and those are listed in this link. Well, we won't be talking about those today because they've already ended, but that's, if you're interested in looking at that, that's located in that link. So here's the document if you would like to see it for yourself again, and the link is listed there at the bottom of the slide. Everyone will be given access to the slides when we are finished. And like I said, it's a fairly extensive document. I've spent a long time with it myself in trying to find the best guidance to give. I really enjoy looking through a really dense document and kind of breaking it down into simple language in order to communicate it forward. So let's talk about guidance for all providers across all healthcare environments. These were the vaccination requirements. So we all know that in November 5th, 2021, CMS issued a final rule requiring Medicare and Medicaid certified providers and suppliers to ensure all staff were fully vaccinated for COVID-19. Now, these slides I created a few months ago, maybe a month ago. And at that point in time in this document, CMS said they would soon end this requirement, more details to come. CMS has ended the requirement. The document that CMS issued around ending of the requirement for the COVID-19 vaccination had a lot of language around continued support and education around getting the COVID vaccine. There is so much research at the beneficial effects of the bivalent vaccine, especially in the long-term care population. We are still having COVID outbreaks in long-term care. I'm sure all of you know. The bivalent provides such wonderful protection for these individuals. If you look at the data around individuals over 80, their risk of death in the 1 year following a COVID infection, if they're unvaccinated, is very high. And we're still getting a lot of data around long COVID and all of the things that they're at risk of for long COVID. So the best guidance for our long-term care population is vaccination. So we want to make sure that we continue to stress education and letting individuals know that the best course of action is to get vaccinated. And that's what CMS stated in the document. So more guidance for all providers and environments, and this is talking about emergency preparedness, training, and testing during or after an actual emergency, which was the public health emergency. Emergency preparedness regulations allowed for a 1 year exemption from the requirement that the provider or supplier perform testing exercises. So inpatient providers and suppliers must conduct a full-scale exercise within its annual cycle for 2023 and an exercise of choice. And outpatient providers must conduct either a full-scale exercise or an exercise of choice within its annual cycle for 2023 if scheduled to conduct the full-scale exercise within 2023. The provider supplier must conduct the exercise of choice, and then the reverse. And if you are interested in what a full-scale exercise entailed or an exercise of choice entailed, as I was curious. So a full-scale exercise is an operations-based exercise that involves multiple agencies, jurisdictions, and disciplines performing functional and integration of operational elements. So this is boots on the ground response activities like a mock taking care of mock patients in a mock disaster drill. This is hospital staff treating mock patients. And then an exercise of choice would be the mock disaster drill or a tabletop exercise or a workshop. So that is that. So let's get into the meat of this presentation as we talk about long-term care facilities. So this 3-day prior hospitalization, which I think many of us have kind of forgotten about. During the public health emergency, CMS waived the requirement that a 3-day qualifying hospital stay was required for a Medicare A Part A SNF covered stay. So patients needed to be in the hospital for 3 midnights if they wanted to be admitted to the facility and have that stay be covered under Medicare Part A. That did not need to happen during the pandemic in order to move patients along and get them from the hospital into the skilled nursing facility to allow more room for patients in the hospital. So beginning on or after May 12th, that 3-day hospital stay is back into effect. So that is required before Medicare coverage will ensue. This is also a little bit confusing. For any new benefit period that begins on or after May 12th, 2023, the beneficiary will need to complete a 60-day wellness period. So this was in effect prior to the pandemic, and it was waived during the pandemic. So now that we're after the public health emergency, we're in this period that 60 consecutive days must go by where the patient is neither an inpatient or of a hospital nor a SNF, which begins on day of discharge. So that's back in effect. Alcohol-based hand rub dispensers. So during the public health emergency, CMS waived the requirement. I cited the federal regulation right there in the, I put a link. So during the public health emergency, that requirement for hand sanitizers was waived in order to allow for hand sanitizers to be on nurses' cart at the nurses' stations, just more availability to staff because of the importance of infection control during the pandemic. And now, obviously, we still have the importance of infection control, but it just allowed for hand sanitizers to kind of be placed anywhere. Now that we are through the public health emergency, the federal regulation is a long-term care facility may install alcohol-based hand rub dispensers in its facility, but they have to be installed in a manner that protects against inappropriate use and access. So in my mind, this means that those hand sanitizers need to be placed in such a way that residents cannot drink from them, do other things with them. So I would say probably having hand sanitizers maybe on the nurse's cart or the nurse station may not be part of this. I think it's, a little bit open to interpretation, but again, I linked the federal regulation link. Pre-admission screening and annual resident review. So during the public health emergency, CMS allowed nursing homes to admit new residents. They did not receive the level 1, level 2 pre-admission screening. Now that the public health emergency has ended, all providers are expected to be in compliance with the requirement of all admissions taking place after May 11th, 2023. the screening has to be done. The medical record for residents with a mental illness or intellectual disability must include evidence of level 1 pre-screening. And if the level 1 pre-screening is positive, level 2 screening needs to be done prior to admission to the facility. So resident, roommates, and grouping. During the public health emergency, CMS waived these requirements that I'm going to go over now, just to allow for cohorting of residents. We were able to move rooms quite rapidly because of the waiver of this requirement. So now, after the public health emergency, the federal regulation is that the resident has to be treated with respect and dignity. They have a right to share a room with his or her roommate of choice when practicable. Both residents live in the same facility, and if both residents consent. The resident has a right to refuse transfer to another room in the facility if the purpose of the transfer is to relocate a resident of a SNF from the distinct part of the institution that is a SNF to a part of the institution that is not skilled nursing facility, to relocate a resident of a nursing facility from that part of the institution that is a nursing facility to a part that is a skilled nursing facility, or solely for the convenience of staff. So this is interesting, and I think we've gotten very used to room moves during the public health emergency because we had a lot of flexibility because this federal regulation was waived, but now it's back into effect. So I think we all need to be very careful about making sure that resident rights around moving rooms and roommates is respected. So resident transfer and discharge during the public health emergency, CMS waived the requirement, and I linked the federal regulation there. Now, the facility must provide advance notification of options relating to the transfer discharge to another facility, and the written notice of transfer or discharge to be provided before the transfer or discharge. And it should be provided as soon as practicable. And so this allowed, during the pandemic, the residents to be relocated to other facilities. So I saw facilities, if there was many nursing facilities, they were sister facilities under the same company, and say they had designated one facility as a COVID facility, they could transfer residents fairly easily because this federal regulation was waived, but we can't do that any longer. So something to keep in mind. Nurse aid training, competency and evaluation programs. CMS waived the requirement that required that a SNF may not employ anyone for longer than 4 months unless they met the training and certification requirements. So this has changed a little bit. Uncertified nurse aides working in a long-term care facility covered by a waiver granted to a state or individual facility will have 4 months from the date that the public health emergency ends, or from the termination date of the facilities or state's waiver if earlier. So you might have to check with your individual facility. They have 4 months to the end of that waiver, or 4 months from the date of the public health emergency ends, whichever one is earlier, to make sure that this nurse aid training competency evaluation programs are complete. This includes those long-term care facilities or facilities in states who are granted an extension of the waiver after October 6th, 2022. And again, the link to the federal regulation is at the bottom if you have any questions. Let's talk about COVID-19 guidance. Even you may have enough of COVID-19 guidance, but I just wanted to make sure that everybody is really solid on what is going on with COVID-19, vaccination, education, reporting, all of that, because I think some facilities are going to get burned in survey in the next half of this year. So I just wanted to talk about that. So CMS was really stressing the core principles of COVID-19 infection prevention, saying these need to continue to stay in place. So facilities need to provide guidance, posted signs at entrances about recommended actions for visitors who have a positive viral test for COVID-19, symptoms of COVID-19, if they've had close contact with someone with COVID-19. Obviously, we don't want visitors who have a confirmed COVID-19 infection or symptoms of a possible COVID-19 infection to come in and visit our residents who are extremely vulnerable and continue to be at risk of COVID. Like I said, we're continuing to have outbreaks in long-term care facilities. And I am pretty amazed in my travels and talking to different facilities and providers working in these facilities about residents and patients. And they'll tell me, we've had residents who've had COVID 2-3 times in the last year and a half. So we really need to be cautious about visitors and making sure that they are aware that we continue to have vulnerable individuals for COVID, and that if they're sick, they should not be coming in to visit, just for respect of the residents. Again, if visitors have a close contact with someone with COVID-19 infection, it's safest to defer a non-urgent in-person visitation until 10 days after their close contact. Hand hygiene is important with alcohol-based hand rub, face covering or mask in accordance with the CDC. And again, I linked the recommendations there. More about signage, making sure that individuals who visit, who are in the facility, still understand what constitutes COVID-19 signs and symptoms, what the infection control precautions are, and what your facility practices are. Cleaning and disinfecting high frequency touch surfaces. And I'm sure all of you are doing that. Appropriate staff use of PPE, continuing effective cohorting of residents with COVID, and testing. I linked the federal regulation there. So face coverings, and we've had a lot of questions about face coverings, and we talk about face coverings. The CDC talks a lot about source control. So source control refers to the use of a respirator, well-fitted face mask to cover a person's mouth and nose, which we know, to prevent spreading of respiratory secretions when they are breathing, talking, sneezing, or coughing. People, if they're at high risk for severe illness, should wear the most protective mask or respirator that fits well, and they should wear consistently. And I will say, I think there's a lot of bias around masks right now. I think when we see an individual who is wearing a mask, we should just respect their choice and not maybe call it out. Even when a facility does not require masking for source control, it should allow individuals to use a mask or respirator based on personal preference, informed by their perceived level of infection based on their recent activities. There's still a lot of individuals who are immunosuppressed who want to prevent getting COVID, and they have a right to exercise that choice. So source control recommendations. This is recommended for individuals who have suspected or confirmed COVID infection or other respiratory infection. If they have a runny nose, a cough, and sneeze, masks should be used. That is source control. Or had close contact, residents and visitors, or a higher risk exposure with somebody with COVID infection for 10 days after their exposure. So we need to keep these source control recommendations in mind, especially as we're going to have survey coming in the next second half of this year. Just make sure that we are continuing to implement everything we need to implement. Source control recommendations recommended in facility by those residing or working in a unit or area of the facility experiencing a COVID or other outbreak or respiratory infection. Universal use of source control should be discontinued as a mitigation measure once the outbreak is over. So if you have an outbreak, source control with masks should be used and then stopped once the outbreak is over. That is, no new cases of COVID infection that have been identified for 14 days. Recommended to facility-wide or based on a facility risk assessment targeted toward higher risk areas or patient population. When caring for residents with moderate to severe immunocompromised we've always done this in the facility during periods of higher level of community COVID or other respiratory virus transmission, have otherwise had source control recommended by public health authorities. So that's when those measures should be utilized. Standard precautions. I think all of us kind of forget about standard precautions, and I linked it there if you wanted a refresher. If COVID is not suspected in a patient presenting for care based on symptoms and exposure history, we should all be following standard precautions and transmission-based precautions if required based on the suspected diagnosis. And then we've also talked about enhanced barrier precautions. That should be utilized in certain situations that I've talked about. And if you have any questions about that, or standard precautions or source control, feel free to email me, reach out to us, and we can help you. So reporting of COVID-19, this has been a little bit controversial. During the public health emergency, all long-term care facilities were required to meet very stringent standards to not only report in NHSN, but also to inform residents, representatives, and families following the occurrence of either a single confirmed infection of COVID-19 or 3 or more residents or staff with new onset of symptoms. So now that the public health emergency is over, all of that is required. NHSN reporting, it's required, except, and CMS listed what is not required. And I will say, they didn't say it's not required. They say they're exercising enforcement discretion. So the requirement that is what is not required now is to inform residents, their representatives, and families of those residing in facilities by 5 p.m. the next calendar day following the occurrence of a single confirmed infection. So all of that is not required. The timeline and how many cases should be reported and all of that. I will say, and I'm going to say it again, families have gotten very used to being informed about COVID outbreaks. And you have families coming in and visiting. And I gave the scenario, say you have an individual and brings in a newborn baby, and they walk into the facility and they see everyone walking around in masks. And then someone says, oh, we have a COVID outbreak. I don't think the family member is going to be that pleased. They might have just expected that they would have gotten a notification because that's what they've always gotten during the public health emergency. So I would just continue to be communicating with families and letting them know what is going on in the facility. Our COVID-19 vaccination reporting, facilities were required to report vaccination status during the public health emergency through NHSN. Facilities are still required to report COVID-19 vaccination. Nothing has changed. We're going to continue on doing what we've done. COVID vaccination education. During the public health emergency, all long-term care facilities were required to educate residents and staff of the COVID-19 vaccine and offer to get them vaccinated. This requirement remains in effect. Education needs to continue. Offering the vaccine needs to continue. It is best practice still. And this is going to remain in effect until May 21st, 2024, unless additional regulatory action is taken before then. I will say this is another little bit of a controversial piece of this document. For COVID testing, during the public health emergency, all long-term care facilities were required to perform routine testing of residents and staff. Now that the public health emergency is over, long-term care facilities must conduct COVID-19 testing in accordance with national standards, such as CDC recommendations. I would go by CDC recommendations for testing. And the next slide, I'll show you what CMS is included for testing, the testing summary. Non-compliance with this expectation, and this is CMS's words, non-compliance with this expectation will be cited in F880 for failure to implement an effective effective infection prevention and control program. I have seen many facilities when a resident has a low-grade fever during the night, and maybe a chest x-ray was done or a urinalysis was sent, but COVID testing was not done. I just think with the next half of this year, I think it's really important to just continue to do the COVID testing. Like we're still having outbreaks. So I think it's important, if you suspect infection, to just go ahead and continue to test for COVID. So this is the testing summary, and I linked it, the site where this is located, at the bottom of the screen. And as you can see, I'll just skip to the bottom. Routine testing, not generally recommended of residents or staff. And if you can see the testing trigger, say you have an symptomatic individual, staff, regardless of vaccination, regardless if you have a staff member, regardless of vaccination status, must be tested if they have signs or symptoms. And then, the same with residents. And then you can kind of go through the chart. I think that this is really good, as a strategy to kind of guide your testing. If you have newly identified COVID-19 positive staff or residents, and they can identify close contacts, then we want to talk about testing all staff, testing all residents, and then you can use this chart. I think it's very helpful in guiding strategy for testing. Infection control surveys. So during the public health emergency, all states were required to conduct focused infection control surveys in 20% of their nursing homes in fiscal year 2023. Now that the public health emergency has ended, all states are required to conduct focused infection control surveys in 20% of their nursing homes in fiscal year 2023. They're not required to conduct additional focused infection control surveys during 2024. So something to think about as we continue through 2023. COVID is not over. The public health emergency is over, but COVID is not over. So really continue to be on guard with your infection control process. Make sure all staff are doing what they need to do in infection control. I think that a lot of facilities have gotten lax with infection control processes. So just make sure you're being really vigilant for all of these processes. So we're going to talk about home health agencies, and there's been some changes with home health agencies. So during the public health emergency, Medicare covered initial assessments and determination of the patient's homebound status could be done remotely or by record review, and sharing of discharge planning was not required. So this allowed for the assessment of homebound status for a home health patient to be done remotely, obviously, because we're trying to socially distance, and so this was the best way to do that. Now the public health emergency has ended, Medicare covered initial assessments and determination of a patient's homebound status must be done by an RN, and detailed information regarding discharge planning must be provided to patients and their caregivers or the patient's representative in selecting a post-acute care provider by using and sharing data that includes but not is limited to another home health agency, skilled nursing facility, inpatient rehab facility, long-term care hospital, quality measures, and resource use measures. So important to note, things have changed a little bit around initial assessments in home health. Rehabilitation skilled professionals performing the initial and comprehensive assessment. So during the public health emergency, CMS allowed any rehabilitation professional, that's OT, PT, or SLP, to perform the initial and comprehensive assessment for all patients receiving therapy services as part of the plan of care, if this was permitted under state law. regardless of whether or not the service established eligibility for the patient to be receiving home care. So this has changed a little bit during the pandemic. So when rehabilitation therapy service is the only service ordered, so that's speech language pathology, physical therapy, or occupational therapy, if this is the only service ordered by the physician or the allowed practitioner who's responsible for the home health plan, the initial assessment visit may be made by the appropriate rehabilitation skilled professional. So for Medicare patients, an occupational therapist may complete the initial assessment when occupational therapy is ordered with another qualifying rehabilitation therapy service. So that's speech language pathology or physical therapy that establishes program eligibility. So a little bit difficult to understand, but again, I linked the federal regulation at the bottom of the slide if you have more questions. So on-site visits for home health aid supervision, CMS waived the requirement for a nurse to conduct an on-site visit for home health aid supervision. So now that the public health emergency has ended, CMS has finalized the provision for aid supervision for patients receiving skilled care every 14 days to now allow for one virtual visit per 60-day episode per patient, and only in rare circumstances. Right, so that's the provision has been finalized for aid supervision for patients receiving skilled care every 14 days. So now, in rare circumstances, a virtual visit per 60-day episode per patient. For patients receiving non-skilled care, the registered nurse must make an on-site in-person visit every 60 days to assess the quality of care and service provided by the home health aide, and to ensure that the services being done by the home health aide continue to meet the patient's needs. Semi-annually, the nurse must make a supervisory direct observation visit for each patient in which the aide is providing services. So the nurse must directly observe the home health aide performing services on a patient. Clinical records. During the public health emergency, CMS waived the requirement for providing medical records and OASIS transmission. OASIS transmission is similar to the MDS, as I understand it. So there was no timeline to provide a copy of medical records, and the OASIS transmission requirements were modified. Now that the public health emergency has ended, home health agencies must provide a patient copy of their medical record at no cost during the next visit or within 4 business days. So if a patient requests medical records, they need to be provided at no cost during the next home health visit or within 4 business days. And then OASIS transmission requirements, 5-day completion for the comprehensive assessment, and then 30-day OASIS submission requirement. Okay, so we'll talk a little bit about hospice. So during the public health emergency, CMS waived certain timeline requirements for updated comprehensive assessment for hospice patients. The update of now that the public health emergency has ended, the update of the comprehensive assessment must be accomplished by the hospice interdisciplinary team in collaboration with the individual's attending physician, and must consider changes that have taken place since the initial assessment. It has to include information on the patient's progress toward their desired outcomes, reassessment of the patient's response to care, and it needs to be accomplished as frequently as the patient requires, but no less than every 15 days. So that is when these comprehensive assessments need to be done and who needs to be present. So the interdisciplinary team with the patient's physician, they need to be accomplished frequently if they are needed, but no less than every 15 days. Hospice aid competency testing. During the public health emergency, CMS waived the requirement that a hospice aide must be evaluated by observing an aide's performance of certain tasks with a patient. So during the public health emergency, pseudo patients could be used. Now that the public health emergency has ended, CMS actually finalized these hospice aids requirements that allow the use of a pseudo patient to conduct hospice aid competency evaluation. CMS also finalized the hospice aid supervision requirements that will address situations if there's deficient practice and where remediation is needed for both deficient and related skills. So some parts of what was waived during the PHE actually was finalized in this case with the use of pseudo patients. So non-core services or QAPI. So hospices were not required to provide certain non-core services, and non-core services are physical therapy, occupational therapy, speech language pathology. Hospices were not required to provide these during the public health emergency. And CMS also modified QAPI requirements so that instead of doing the extended QAPI, hospices just needed to focus on infection control issues around COVID mostly. Now that the public health emergency has ended, hospitals must provide certain non-core hospice services for physical therapy, occupational therapy, and speech language pathology. And hospice services must develop, implement, evaluate, and maintain an effective, ongoing hospice, data-driven, home health assessment-wide QAPI program process. So I linked both of those federal regulations at the bottom of the slide. QAPI is really important, we know. So the whole federal regulation is listed there. So some compliance timelines beyond May 12th. Hospices and home health are required to have a registered nurse, or in the case of a home health, a registered nurse or other appropriate skilled professional. This is a physical therapist, occupational therapist, or speech language pathologist to make an annual on-site supervisory visit direct observation for each aide that provides services. So compliance will be expected by July 11th. So a little bit of extra time. Intermediate care facilities for individuals with intellectual disabilities are required to ensure that each client receives a continuous active treatment program. Consists of implementation of a specialized and generic training, treatment, health services, and related services. On September 30th, 2023, compliance is expected for the hospice must assess the skills and competence of all individuals furnishing care, including volunteers furnishing services, and as necessary, provide in-service training and education programs where required. The hospice must have written policies and procedures describing its methods of assessment of competency and maintain a written description of in-service training during the previous 12 months. So that's a lot, especially since volunteers also need to have in-service training. Compliance expected by December 31st, 2023. Home health agencies and hospice must ensure that each aide receives 12 hours of in-service training in a 12-month period. Hospices must use volunteers. So at least 5% of total patient care hours of all paid hospice employees must be volunteer hours. And then I talked a little bit of intermediate care facilities. This will be included in tomorrow's webinar. Intermediate care facilities must provide sufficient direct support staff so that direct care staff are not required to perform support services, and they can spend more time with direct client care. And then federal qualified health centers are required to ensure that physicians provide all medical directions for clinics or center healthcare activities and consultation for and medical supervision of healthcare staff only with respect to medical supervision of nurse practitioners. So that all of those facilities need to be in compliance by December 31st, 2023. And so you're all going to get the links to this presentation, and I encourage you to use them in, and if you have any questions, we'll go through them now, but you can always refer to this later. And here's this. And I think,
All
Kathy,
right.
are you still
Well,
there?
go ahead and go back a slide. We'll
Okay,
get to the post knowledge check here in a minute after the discussion.
okay,
All right, let me get my script back up. I put the link in the chat to these presentation slides. So if anybody wants to find these resources and yours in your citations, that is now there. And I will be emailing everybody later this week with a link to this recording, this presentation slide, a link to the evaluation, and any other resources needed. So if anyone missed finding all this information in the chat, didn't get a chance to open it, or you lose track of it, you'll be getting an email from me later this week with all of that information. So we will begin the Q&A here in a moment. If you have a question, please enter it into the chat or by using the Q&A tool. And you can also raise your hand if you would like to be unmuted to ask your question out loud. But first, I'd like to run over a couple closing items. Dr. Storm, there is a question in the chat if you want to go ahead and review that after I'm done running over these items.
okay.
All right, so first I'd like to remind everyone wanting CEs for today, for today's webinar to stick around after the discussion, and we will direct you to the post-webinar evaluation. And I'd like to also invite everyone to join us for next Wednesday's webinar, which will be a live Q&A with our panel of health experts. If you have a question about the PHE, NHSN, post-COVID syndrome, or any other topics related to long-term care, please join us for that discussion next Wednesday at 2 p.m. We also invite you to bring your questions to our virtual live chats every Tuesday and Thursday at noon. Deborah Wright will be there to answer your questions on topics like quality improvement initiatives, infection control, or MDS coding. You can find the links to those live chats in our webinars in the newsletter we send out each Friday called the Last Minute Lowdown. If you would like to receive that newsletter but don't think you're on the mailing list, you can email me at caudill@qualityinsights.org, and I will get you on that list. And I will drop my email in the chat shortly with that, where you can contact me if you need to. So Dr. Storm, one person asked, did I miss you saying something about staff mandates for vaccine or exemptions in long-term care?
Yeah, so the mandate for the vaccine has been lifted, though all facilities need to continue to provide education around the COVID-19 vaccination and provide the COVID-19 vaccination if the individual would like to receive it. So all of that needs to continue, education.
Great, thank you. And that's the only question we have so far. If we'd like to take another minute, see if anybody else has a follow-up question. Of course, as I said, we'll have a Q&A next week if you have a question that we don't get to ask today. All right, well, I guess we can continue on to the CE portion. Oh, wait, we do have a question. Do you have any resources for medical director education? That is
so I mean, all medical directors should be aware of what is going on in long-term care with the end of the public health emergency. So I would share this with your medical director. There is a requirement now specific to, I don't know if you're in Pennsylvania, but there is a specific requirement now it's going to be required as of July 1st in Pennsylvania, that all medical directors have 4 hours of continuing medical CME around post-acute and long-term care. So your medical directors are required to have 4 hours of CME around post-acute, long-term care, nursing home medicine after July 1st if you're in Pennsylvania. So that's something that they'll need to look into.
She said, yes, Pennsylvania. That is why I was asking where they offer the correct education for PA LATC.
Yeah, it's really challenging. I actually was reaching out to some colleagues at the Pennsylvania Medical Director Association today around what is being done education-wise. I will say that there is a tremendous amount of education available at AMDA, the American Medical Director Association. There's a tremendous amount of education available for individuals, for physicians who want education. CME is required. You might have to be a member. Some of their education you actually have to pay for. I think it's going to be extremely challenging for physicians who are not members of certain long-term care societies to get the education because they're going to have to pay for it. So we're actually kind of talking about what we can do to provide that education. We're not ready yet, but perhaps more information to come.
We have another question here that says, is there a CMS QSO about lifting the vaccine mandate?
There is.
Is it in your slides? If so, I can copy and paste
I
it.
don't think it's in my slides. I don't think it's in my slides, but we can kind of send it out. I should have probably included it. I don't think it's in my slides. I don't know if anyone else on the call has that link.
I can include that in the email I send
Okay.
later this week. Okay, if there's any other questions, go ahead and get that in now, or raise your hand if you would like to ask your question out loud. If not, I'm going to continue on to the continuing education portion. And I'm going to go ahead and drop this link to the link that you're seeing on screen. Okay. All right. So for those of you who are interested in, sorry.
I think there's another
I
question.
think that is the last slide. Is it? Oh, there is another question.
Yeah. When a resident has signs and symptoms of colds or etc., should we isolate? So I will say this is like source control, right? So I would be very careful. I would look at the individual resident. I will see if they have if a fever, and I would certainly pull in your medical director and look at if they had possible, maybe they went out, they were at a restaurant, or they had a family member visit that maybe said that they had COVID, they didn't realize it. So I would look at the whole situation, and if everything fits together and it looks like, yeah, they probably have COVID, then I would probably isolate. But if it's just like runny nose, if it's maybe could just be allergies, I think you really have to just do a case-by-case basis. You can't go wrong with asking the resident to wear a mask. So I think that's important.
Thank you for that question. Jennifer Brown, our infection preventionist, dropped a link in the chat for that.
Nice.
Oh, thanks, Jennifer.
Thanks, Jennifer. Save the day.
I'll go ahead and include that in the email too for anyone who. There we go. Okay. Well, now I will talk about the CEs. Okay, so for those of you who are wanting CE credits for nursing, go ahead and stick around for just another minute. If you are not wanting CE credits, please ignore the pop-up window when you exit the webinar. And if you're not sticking around for CEs, you can sign off at this time. So thank you so much for joining us today. Okay, so as I said at the beginning of the webinar, those of you who are interested in CE credits will need to complete an evaluation. In order to receive your free nursing CEs and certificate of completion, you'll need to, complete the evaluation and post-knowledge check. Once you successfully complete the post-knowledge check, you will be forwarded your certificate. So as you can see here, we have a few ways to get you to that evaluation. You can scan the QR code on the screen right here, or you could type in that small URL that's on the screen, but I also dropped the direct link in the chat, and you could just click that link. And then, as I said earlier, there will be a pop-up when I end this webinar with the link too, just in case anyone's having trouble finding it. And lastly, of course, I will put it in that email that I'll be sending everybody either this afternoon or first thing tomorrow. Just a second, I see Cindy is asking, oh, I'm sorry, Cindy, that memo was sent to just the panelists. So Jean and I saw it and the rest of you did not. So I just copied and pasted it into the chat, and now you all should be able to see the QSO memo that Jennifer sent us. So sorry about that. Sometimes I miss seeing if it wasn't sent to everyone. There we go. Okay, so everybody have a moment to click that link. And again, if anybody is wanting to get CEs, I'll be here just another minute just to direct anyone who's having trouble getting to it. But as soon as I hit end on this webinar, you should be able to get to that link. And if you don't have time to fill out the CE, if you want CEs but don't have time to do it right now, you can just wait till you get that email from me and get the link that way. All right. Hopefully everybody had a chance to click all those links. If not, again, look for that email. Dr. Storm, thank you for this presentation, and thank you to everyone who joined us today. I'm going to go ahead and click end on this webinar and look for emails from me if you have any troubles accessing these, getting to the post knowledge check if you're wanting CEs. Thank you for joining us today.